Regional Referral Hospital, and I'm delighted to be your moderator for today. Hemodynamic instability remains one of the most critical cases in acute management, and today's session, we aim to understand how to recognize, manage, and coordinate care for such patients. We have a rich panel of experts and practitioners who are within the house and some are online, and I would like to invite each one of them to briefly introduce themselves. Dr. Agri, kindly introduce yourself.
Good afternoon, everyone, especially the team online. I'm delighted to be part of the presenters today. My area of work is anesthesia, critical care, and evacuation medicine. I work in Kawempe National Referral as a consultant, but also I lecture at Macquarie University with and KIU students in anesthesia and critical care.
Ms. Nachiemba, kindly introduce yourself.
Good afternoon, everyone. My name is Nachimba Kevin. I'm an EMT working with the Ministry of Health, Nagulukol and Dispatch Center, and Nankula Medical Center, Luwafu. Thank you.
Thank you. Mr. Mbabazi, kindly introduce yourself.
Good afternoon, everyone. My name is Cesar Mbabazi. I'm a nurse, cardiac nurse at Uganda Institute. I work in the emergency area and the critical care areas of Uganda Institute. Thank you.
Dr. Emmanuel, kindly introduce yourself.
Thank you. Good afternoon, everyone. My name is Dr. Emmanuel Baruch. I am a resident in emergency medicine at Mbara University of Science and Technology, and I am in my second year of residency. Thank you.
Dr. Sarah, kindly unmute and introduce yourself.
Good afternoon, everyone. I hope you can hear me fine. I'm logging in from Bara. I am Oina Sarah, as I had earlier said. I'm an emergency medicine physician currently volunteering with Bara University of Science and Technology. Thank you.
Thank you so much. Audience, kindly ensure your microphones remain muted and feel free to engage in the chat for any questions or comments. And I would like to invite 2 to 3 participants to tell us what their expectations are for this session. Kindly raise your hand and you'll be given a chance to speak. Yes, Mr. Joseph, kindly unmute and tell us your expectations.
Thank you so much for this opportunity. My name is Dr. Mbao Joseph, and I would like to give me some highlights on the management of acute myocardial infarction with the hemodynamic instability. Yes, thank you.
All right, that is well noted. Anyone else? For the rest, you can still continue to type your expectations on the chat. Right about now, to kick us off, I will invite Dr. Emmanuel to take us through the case presentation.
So I will be presenting a patient that we had this week who came in with symptoms that are of interest given our topic today, and we shall have a discussion as we go along. So this was a 74-year-old male patient. This is a 74-year-old male patient who came in as a transfer from a peripheral facility. He reported 3 days of severe chest pain and difficulty in breathing. And the chest pain he reported as acute onset associated with palpitations and dizziness. At triage, his blood pressure was noted to be high, and the recording was 220 systolic of 120 millimeters of mercury. The quick primary survey that was done by the team that saw the patient initially, the airway was parted and protected. He was tachypnic, breathing at 36 breaths per minute, saturating at 98% on room air. And there was equal air bilaterally, but decrease at the bases, did not have crepitations. On circulation, he had cold extremities with a delayed capillary refill of more than 3 seconds. Pulse rate was 86 beats per minute, regular. Blood pressure, as noted earlier, was 220 over 110. No descending neck veins. Heart sounds 1 and 2 were heard. There were no added sounds. On disability, he was confused, so he was given a GCS of 14 out of 15. Motor scored 6, verbal scored 4, eye response scored 4. Pupils were 4 millimeters in size, bilaterally and equally reacting to light. There were no focal neurological deficits. The blood sugar that was done on admission was 1.7 millimoles per liter. On exposure, he was a febrile, temperature was at 6.4, had mild conjunctival pallor, no edema, no jaundice, no cyanosis. So we would like to know from the audience, given the information that we have so far, what are the three bedside priorities that we have for these patients as we want to intervene and start the care for the patient?
The audience will be launched on your screen. Kindly attempt Dr. Emma, can we proceed with our
Yes.
case presentation?
Let's continue. Thank you for the poll. So we are now going to tell you what was done for the patient and the three priorities that we had. One was hypertensive emergency. Second was cardiogenic shock in the context of chest pain and features of shock. And then hypoglycemia, evidenced by the very low blood sugar of 1.7. So with the hypertensive emergency, the blood pressure was 220/110, and the initial team that attended to the patient were worried of complications such as stroke and end organ damage that will involve the brain, the heart, and the kidneys. So what was done for the patient is he was given antihypertensive medication. So labetalol 20 milligrams intravenously was given. And they also added nifedipine 40 milligrams orally. And with cardiogenic shock, IV access was established. There was a request for a 12-lead ECG and blood samples to be taken to the lab for analysis. For hypoglycemia, that was corrected with 50% dextrose. And there was also effort to actually reassess the patient so that the response to this treatment is monitored to see if the patient is getting better or worse or stays the same. So as we always assess and reassess our patients in the ED, there is probably a question if labetalol and nifedipine, labetalol 20 milligrams IV and nifedipine 40 milligrams per oral, were the best choice antihypertensives based on the information we have up to this point. So as the patient was being reassessed, the blood pressure rapidly dropped from the reading we had earlier to a systolic of 50, diastolic of 30. Now, what does the doctor do for this patient? What are the options that we have?
The audience can be attempting this question.
So the question we have here is, based on the above information, what are your management options for this patient? We only want at least one choice from the 5 that we have here. So 1, you give a liter of fluids. 2, you give phentolamine. 3, you give adrenaline as an IM dose. 4, you give an adrenaline infusion. And 5, you give an noradrenaline infusion. So those are the options that we have, and you could pick one of those and see. you for those who have taken part in the poll. Now we are going to tell you what actually was done for the patient. So with this, when the blood pressure was noted to be 50 out of 30, the team that had initially seen the patient now called the emergency medicine team to actually come in and review the patient. So when we got there, they had given the patient a liter of normal saline as a bolus, and they had started the patient on an infusion of adrenaline at 4 micrograms per minute. And with these two interventions, the blood pressures actually improved, but remained labile through the night. So systolic blood pressure was ranging between 90 to 160, and diastolic was 50 to 80. So this was good because this actually bought the team some time to find out more information about the patient and see how best we can together manage the patient as a team. So with the signs and symptoms from our sample history, we know that he came in with acute onset of chest pain for 3 days and shortness of breath. And on initial assessment, he was confused and restless. He had no history of food or drug allergies. With medications, he had come from a peripheral facility and he didn't come with any documentation. So there was a gap. We actually didn't know what was being managed for the time that he was in that facility. So on his past medical and surgical history, the family said that there was history of prostate surgery 10 years ago. Serostatus is a no history of trauma, non-smoker, non-drinker. The last meal was 8 hours prior to admission at Mbarara Regional Referral Hospital. And the events that led up to his presentation was that he was unwell for 3 days, and that's when he was taken to the peripheral facility for those 3 days with the symptoms of chest pain and shortness of breath. So that means by the time he was coming to us, he was 72 hours after the symptoms, after the onset of symptoms. So he was in that facility for 3 days. We did not know what was administered because he didn't come with any documentation. He came in our facility in the emergency department at 9 p.m. And that's when the BPs were high. The initial management of labetalol and nifedipine was instituted. And 2 hours later, that's when the emergency medicine was called, when the BPs were crashing, following the labetalol and nifedipine. So that's the sample history that we got. On secondary survey, the relevant positives from the examination was that he was hypertensive. BPs had now improved just a little bit to 80 out of 60, but there was that range. There was a differential of blood pressure. It was higher on the right. Measured on the right arm, it was higher than the left by about 30 millimeters of mercury. He was bradycardic. The lowest heart rate that we recorded was 42 breaths per minute, and the highest was 64. He still had persistent tachypnea at a rate of 38. He had very cold peripheries. He was still confused. Per abdomen, he had right upper quadrant tenderness, and he had come in with indwelling urethral catheter. And we noted that from the family, what they told us is the catheter had been in for more than 8 hours, and the urine that had collected was less than 50 mils. So there was oliguria as well in the systems as we examined him. So negatives, he was a febrile. There was no cough, no crepitations, no rash, no edema. And this summarizes now our primary survey, secondary survey. And at this point, we would want to investigate the patient. But before we go to investigations, we would like the team that was attending to this patient just to get to know the thought process of what was going on in their mind, given the story and the findings of the physical exam. And they came up with a list of differentials that we have here. So in emergency medicine, there are a number of mnemonics that you can use to populate your list of differentials. And the one that we commonly use is the vitamin. So you think, are there any vascular causes? Are there any infectious causes? Is it trauma or toxins? Are there any autoimmune causes to this presentation? Are there any metabolic causes, any iatrogenic causes, or any neoplastic causes? So on the vascular causes, number one on the list was an acute MI, given his presentation. We thought also he could have an aortic dissection, a spontaneous coronary artery dissection, a pulmonary emboli, or Takotsubo syndrome. Infectious causes, we thought, will it be a myocarditis or could it be TB pericarditis, given that we don't have a lot of information from the history. So really, a lot of these things they were all possibilities. So trauma, we thought, could it be a myocardial contusion or ingestion of toxins like phosphide poisoning? Autoimmune causes, either SLE or sarcoidosis. Metabolic, given that he had severe hypoglycemia, we thought, was the patient starved? Iatrogenic, which is probably another very important differential here. Was it that the initial team that analyzed the patient were treating a number and not actually a diagnosis of hypertension, because he was given beta blocker and a calcium channel blocker that rapidly dropped down his blood pressures? And then neoplastic causes possibly could be a pheochromocytoma. So that is the list of differentials that we had. And then now we went ahead and did bedside investigations, as we always do for patients in the emergency department. So what you are seeing on the screen is, this was his cardiac point of care ultrasound. And on the left, that's the parasternal long axis view. And then we have the parasternal short axis view. And what was significant on this finding is that, one, there was reduced left ventricular contractility. It was very poor. If you could just go back to the previous, just look at the left atrium was dilated, as you can see from the long axis view, the one on the left. Found this out. Okay. So this is showing us the long axis view, and you can see that the left atrium is very dilated compared to the other chambers that we are seeing. And also of note is because we also thought, still can't hear? We also thought that he could be having an aortic dissection. The aortic root that we were able to see, that part of it, there was no flap. So that ruled out an aortic dissection as another significant finding from the cardiac focus. So what we picked here was the reduced contractility and the dilated left atrium. If you look at the second, the one on the right, the video on the right, we are seeing that his contractility was very poor, and the inferior wall, lateral wall, inferior and lateral walls were actually hypokinetic. Then when we now look at the four-chamber view, yes, for the apical four-chamber view, this does not really pick it out clearly, but we actually thought maybe he had some aneurysmal changes on the left ventricular wall. The other bit that we saw was the plethoric IVC, and given the changes that we saw, the regional wall motion changes, we thought maybe he actually had a large myocardial infarct. Occlusion myocardial infarction, large occlusion myocardial infarction that actually was involving the anterior wall, the septum, and the posterior wall of the heart. So that is what we went with, given these findings that we had. And I've already mentioned that looking at the aortic root, there was no flap, so we ruled out an aortic dissection at the root. We were not able to rule out on the whole aorta because we were not able to get further investigations. So on more tests that we did, we were not able to do a 12-lead ECG, but the patient was connected to a monitor, and we tried to pick something out of the 5-lead ECG that was on the monitor. And what we clearly picked out was that he had wide complex QRS, wide QRS complexes. There was also ST elevation in AVR and lateral leads, which, when we put these findings of the 5-lead ECG and the point of care ultrasound of the heart, probably we were still thinking of a large main occlusion that involves the septum, the posterior wall, and the inferior wall. So with the blood results, what we were able to do, we did a full blood count, which was unremarkable, normal parameters. His random blood glucose after the initial resuscitation with glucose was 4.1. We've talked about the ECG changes. His electrolytes, creatinine was slightly elevated at 1.38. The higher limit is 1.3. Urea was normal, 40. He had a hyperkalemia, very mild, of 5.52. Sodium was normal and chloride were normal. Troponin, this is cardiac troponin I, or 0.09, which is normal. He had an elevated CKMB. We're not able to do arterial, gas, CRP, and blood cultures because we still, given our list of differentials, we wanted to rule in and rule out some of the things that we were thinking about after our secondary survey. So given these findings, we now are going into management of the patient in the emergency department. So a question to the audience is, what is the target saturation for this patient? If you have a patient that is suspecting an acute MI, what is your SpO2 target? So I'm going to repeat the question. What is the target SpO2 in the management of acute myocardial infarction? And the options we have on the screen here, one is 100%. The second is 95 to 99%. The third is 90 to 93%. And the fourth is 85 to 89%. So on supportive management of this patient in the emergency department, there are a number of targets that we have and a number of systems that we want addressed given his presentation and the findings. So back to the question that we had about the oxygen saturation target for patients with acute myocardial infarction. Our target was between 90 to 94%, and this is, we have this scientific reference from the AVOID study, which actually, following that, now there was now an international consensus that said for patients with acute myocardial infarction, there was, from the study results, there was more harm to those patients who were given oxygen levels above 94%. That means they were on oxygen and their saturations were over 94% compared to patients who were between 90 to 94%. So given the results of that study, we thought that it the best thing for this patient was to keep his saturation between 90 to 94%. as we monitored him in the emergency department. Then vitals monitored closely. Urine output, we had earlier mentioned that he was oliguric, so it was one of the things that we actually targeting as we manage the patient. And then because he presented with acute chest pain, we also need to bring in analgesia to ensure that the patient is comfortable and calm. So the first thing on the list here is suspected late presentation myocardial infarction. That means he's out of the window for a number of interventions that he will have benefited from. So what we did was he was given aspirin and clopidogrel and enoxaparin 80 milligrams subcutaneous. And then we were still chasing to get a formal 12-lead ECG and pain management, which we did with morphine. He got 2 doses of morphine, 6.5 milligrams, about 6 hours apart. And saturation, as we've already mentioned. So given that he was in cardiogenic shock, we had targets for this patient. One was his blood pressure. If we are thinking about perfusion, because this is a patient who has cold extremities, is a patient who is not making enough urine. So we want to have adequate perfusion so that he actually perfuses his kidneys, but also we don't want to burden his heart. We don't want to increase the myocardial demand for oxygen, so that and that will actually worsen his ischemia that was ongoing. So for this second beat, we actually went with a low dose noradrenaline, which we did at 2 micrograms per minute, and that's what we started with. And we were aiming a low normal blood pressure, or you would say we were aiming a map of around 65, about 65 to 75, just so that we have adequate perfusion, but also not increase his demand. This vasopressor, that's noradrenaline, will increase our afterload on the heart, and that will give us a very good blood pressure. And then the second beat also, because the heart is failing and there is very poor contractility, we want to increase its contractility. That's the chronotropy, and we went with dobutamine. So what came in first was noradrenaline, and then we added dobutamine, still starting at a low dose at 10 micrograms per kg per minute, so that we also don't increase his oxygen demand and increase the heart rate too fast. Sorry. So the idea of adrenaline was off the table, because adrenaline will now do the things that we don't want it to do on the heart that will actually worsen our patient. Then the third bit was the kidneys. So we want to improve renal perfusion. So targeting a low normal blood pressure, of course, will give us that perfusion to the kidneys, and the patient now should be able to start making urine, because we were thinking possibly he was starting to get into prerenal AKI. And then because we want to reduce his, because you see the chambers are full, that means there's a lot of workload on the heart. We want to decrease that volume. So gentle diuresis with furosemide, dose of 40 milligrams, that will help reduce the load on the heart, and also slightly reduce our potassium, which was high. And that is what we did for the patient for this third target. So in the emergency department, we always think about disposition when you have patients, especially critically ill patients, and we want to think about it from the time we actually are attending to the patient. So for this particular case, what we did for them is we engaged the family and informed them that this is a patient who has suffered a severe cardiac insult. He requires long-term support. He probably might not return to his baseline cardiac function, and the prognosis at this stage is guarded, because possibly with a good facility and good resources, he might pull through, but then we do not want to commit on that. And then we wanted to bring in the multidisciplinary teams, cardiology, internal medicine, and critical care. So one, we wanted to cardiology to come in and see if this is a candidate actually who will benefit from either PCI versus coronary artery bypass, titration of his medications, because we were already on pressors and ionotropes, and then also get a formal transthoracic echocardiogram. And then ICU review, this is the patient, as we already put it, he's on pressors, so he needs invasive monitoring and management of his hemodynamics, and he might get worse before he actually gets better. So this is best done in a controlled setting, and this is actually what is done in ICU. So wanted the critical care team to come and see the patient and admit him for that purpose. Follow-up in the ED, he remained in our emergency department 24 hours, and when we saw him the following day, clinically he had improved, not in distress. His pain was well controlled. We were still doing the two pressors, noradrenaline at 2 micrograms per minute and dobutamine at 10 micrograms per kg per minute. His vital signs, our blood pressure was now 104/71, heart rate of 91, SpO2 92 to 95%, slightly higher than what we had intended to give. Chest was clear, and he was breathing at 24 breaths per minute, and he was now having a normal urine output of 0.5 mils per kg per hour. So
thank you so much, Dr. Emmanuel, for that informative and relevant case. It sets a solid foundation for our discussion. I now invite Ms. Kevin to take us through the interfacility care and transportation.
Thank you so much, modulator. My name is Nashimba Kevin, an EMT. So as we are transporting this patient, these are the things we need to prepare. We need 2 EMTs and the ambulance, but there are some situations where there is 1 EMT, you can guarantee respond to the case. Then we need the ambulance driver. Then we need the medical support. Those are the people you call in case of anything, in case of an assistance. Then we go to the patient. You consider the risk and the benefit analysis. Will this patient benefit from here or from the facility you're taking him or her? Then notify the receiving facility. You call those people where you're taking the patient. You tell them the condition of this patient so that they prepare to receive you. Then you get the referral letter, get the investigations done. Then you brief this patient if in case he's conscious. If he's not conscious, you talk to the caretakers about you tell them what's going on. Then you go to the equipments you need and medication. We have a patient who is hemodynamically unstable. So the equipments we need, you first do the function check. You check the ambulance, whether it is in good condition, whether it has fuel. You check the defibrillator, the vent, suction machine. You check the cardiac monitor, whether it is functioning very well. Then you get your medication that you're taking. You get the medication this patient has been getting from this referring facility. Then you get those are the vasopressors, the morphine. You get the IV fluids, the management of MI. Then you check your supplies, those are ambulance linen, the pillows, etc. Then you choose the type of transport, the type of ambulance you're using when transporting this patient. Remember, you have a critical patient. This patient needs a type C ambulance. You get a type C ambulance, which is the moving ICU. We have those ambulances, the type A, where you just load the patient and go. You just monitor. The type B, where the patient needs not much attention, but type C, it is where this patient is critical. You use the moving ICU, the ambulance that has everything like an ICU room. So you go to the documentation and handover. We normally have a patient care form. That is a form where you document whatever you've done on transit. Any intervention done in the ambulance, you document in the patient care form. You give in your verbal report and written there. We normally use the ISBA acronym, where I stands for you identify yourself, the S for situation, background, assessment, and the recommendation. So first, identify yourself, like your name. My name is Nachimba Kevin. Then you talk about the patient. With me is a 74-year-old male. Then you go to the situation. The situation this patient is presenting with. This patient is hemodynamically unstable. He has a history of difficulty in breathing, chest pain, oliguria, confusion. He has a history of prostate surgery 10 years ago. Then you go to your assessment. When we are transporting these patients, we normally go on monitoring. You have to monitor your patient from the time you've got the patient until you hand over that patient. You use the ABCDE approach. You check for airway. If it is patent, that's okay. If it is not patent, you look for what is the cause. Fluids, you suction. You make sure your patient has a clear airway. And in our case, our patient, the airway is patent and secured. Then you go for the breathing. Our patient has difficulty in breathing. Whatever you find, it is anything you find that is not okay, you correct that thing. Our patient has you check for the circulation, you do the inverted DJ. Our patient has the SpO2 of 92 to 95 and is on 3 liters of oxygen on nasopharynx. Then the respiration rate of 24. The patient has the DCS of 14. We have a blood pressure of 104, systolic and diastolic of 71. Then you go on checking until you reach on E. Then you give in after the assessment, where we use the ABCDE, you go for the recommendation. What you recommend these people that you're giving the patient to do. So according to the patient that we have is hemodynamically unstable, I recommend the patient should be reviewed after the intervention of a cardiologist. Thank you.
Thank you so much, Ms. Kevin. To the audience, if you have any comments or questions, please kindly type in the chat. Dr. Sarah will be responding to a few of them. Allow me invite Mr. Mbabazi Caesar to take us through the emergency nursing approach to a hemodynamically unstable patient.
Thank you, Dr. Betty. The audience, my name is Caesar Mbabazi. Once again, I'm a nurse, cardiac nurse. Okay, good afternoon, members. My name is Caesar Mbabazi. I'm a cardiac nurse at Uganda Heart Institute. I'm glad to be here and to speak to you about nursing care of a hemodynamically unstable patient. So as I've told you, I worked at the Uganda Heart Institute, and a patient like this one presented is what we receive every day. So most of our patients are almost like this. They are hemodynamically unstable, and we are going to go through how we would handle it as a nurse. So as nurses, you know that we do holistic care. Holistic care, we are there for the patient in everything. Not only the pathologic part, but the entire patient. So when you receive a hemodynamically unstable patient, the key is early recognition and early stabilization. So we begin by doing a quick assessment. I'll follow ABC, ABCD, do airway and breathing. So in this particular patient, we see that I was breathless, though the SpO2 was okay, but the patient was was breathing so fast. So you change the position of the patient immediately, make sure you sit the patient up. Of course, I would say that you put the patient at an angle, around 45 and above degrees, but depending on where you work, you may not have those beds. So you can improvise a way, but make sure that the head of the patient is raised up. You can use pillows, you can use blankets, whichever you improvise as a nurse. This patient can't lie flat in bed because you have to improve their breathing. Then SpO2, we've been told this patient's SpO2 was 98, but you might receive a patient whose SpO2 is low. So oxygen. You don't need to be told, please connect oxygen. Once you've done initial assessment and the oxygen is low, connect oxygen. Then, as you continue in your assessment, observe for signs of respiratory fatigue. I mean, dropping SpO2. So for this particular patient, he might have come with an SpO2 which was good, but as time goes on, it might keep dropping. So make sure you keep observing for use of accessory muscles, cyanosis, especially in babies. Cyanosis is very important, and accessory muscles and decreasing SpO2. Then treat the chest pain immediately. Immediately treat the chest pain. You can't continue doing anything when the patient is in pain. So in this case, we might use morphine to treat the pain. And you know, as we are working, we are liaising with doctors. What they prescribe is what you give or you discuss with them. So we are doing holistic nursing intervention. So as you're doing this, a patient has just arrived, please provide assurance. Calm the patient down. This patient is, we have seen the GCS is a bit low, is a bit confused, is breathing so fast. So you need to reassure this patient and the caretakers so that you calm them down. Otherwise, your care will be very hard. These people can keep moving up and down. They are fearing. Remember, they have spent 3 days in hospital. They are not seeing any improvement. So make sure you reassure them and calm them down. That's our work as nurses. And involve the family from the start. Don't leave the family behind. Involve them in their care and let them support you in the care of this patient. And explain everything that is happening in a very simple language so that they understand what you're saying. Then I was still at AB. Then C, make sure you put a large bore cannula. Large bore. If you can put a gray cannula, that would be the best. But if you can't, at least put a green or pink. And if you can't, just put 2 on both hands. But make sure you put IV access, which is large. I don't know why you'd put a blue cannula in an adult who is hemodynamically unstable. We need big cannulas because you might need to resuscitate, give various medication. example, as you've been told, this patient is on ionotropes. If you are in our center, would also require a central line because we are giving ionotropes. We give ionotropes on central line, but at least if you're in a lower center, you can't access the central line, put a large bore cannula. So monitor these BPs closely, 10 to 15 minutes in an emergency situation. If you don't have an auto machine, do it manually. You can do it. In good centers, we just set, you press a button and it keeps recycling every 15 minutes. But if you don't have it, please take this patient's BP. This patient's BP is very high. Given some medication, you need to monitor it. Assess for perfusion. You have said the peripheries are very cold. Capillary fill time is low. I've seen the urine output is low. Given the cold extremities, please provide warmth to the patient. Patients who are cold extremities, give them blankets, cover them up. And as you're covering them up, ensure privacy. You know, we have messed up emergency units, but we may not have curtains, we may not have private rooms, and this patient, even if you had a private room, would not go in a private room because he's in an emergency situation. So get away of providing privacy. Sometimes we have screens in those wards. Let's use them to provide privacy to our patients. Immediately correct the hypoglycemia. We've seen has an RBS of 1.7. Hypoglycemia is a silent killer. You know, as nurses, we do many things and we forget to check the RBS, just simple RBS. In an emergency, make sure you check RBS. It might actually be the problem. As simple as RBS. And we have history that this patient last had a meal 8 hours ago. So check RBS and correct it immediately. So our patient had 1.7 RBS, which is critically very low. And what do? Make sure you give D50. We gave D50 in this patient, but you may not have it. You know, our lower centers mostly, sometimes they don't have the D50. Or the patient, if the patient is able to swallow something, at least give glucose. And if you don't have glucose, give sugar, water sugar, but give something. Insert an energy tube if he's unconscious and you don't have a D50, and give something sweet to correct this RBS and constantly monitor it. Right? So we saw in this case that the BPs were corrected. We are told it was an intern doctor on duty. You are ordered to give labetalol 20 milligrams and nifedipine. And this is where we come in as nurses, that we also need to be updated on the current practice. If I was the one, I wouldn't give this nifedipine of 40 milligrams, because to me it looks like a big dose. And no wonder the BPs dropped drastically. So we need to collaborate with our doctors and sometimes talk to them about some of these issues. They don't just tell you give this and you give. If there are issues and maybe these patients were to sue for any reason, you'd also not survive. So let's also, as nurses, need to keep updated on the current practice. This was the management of this BP. Had the question marks. I think this hypotension that came up was iatrogenic from these antihypertensives. So as nurses, we are advocates for patients. Let's always advocate for our patient. In whatever, just know you are the one who is there for the patient. Just assume that you are the one standing in for the patient. So in this case, you have to stop the antihypertensives that you're giving immediately and notify the doctor. Let's always keep in touch with our doctors. Don't do things in isolation. Doctor might have prescribed and left. Always keep updating them because we are managing these patients together. So we are giving a fluid resuscitation after all this. This is also another issue. You see the patient has a weak heart from the presentation. So when we are giving resuscitating with fluids, we need to do it slowly. Unless someone is bleeding, has hypothalamic shock, and they are sure of it. But in this case, have signs of cardiogenic shock, we already have a weak heart, we don't want to overload it with fluid so quickly. So the doctor might just write, give 1 liter, and you pour it in, and the patient is overloaded. Let's take it slowly when we are resuscitating patients with fluids. We don't want to overload an already weak heart. And we initiated ionotropes. Now, doctor might tell you to give ionotropes, gives you the dose, which is very okay. And you don't have a pump. In these centers, people use infusion pumps, but you may not have infusion pumps, and yet you need to give ionotropes. You can use drip rates. You can calculate drip rates. Our giving sets have drip rates, and you can clearly set the dose you want. So there is no reason you can say, I want to give these ionotropes because I don't have a pump. Our simple drips can do it. And please make sure you calculate. Don't just time with your eyes. We nurses have a tendency of looking at the drop. This is okay, it is moving. So let me increase. You have to calculate the drop rate. But because these ionotropes can change a patient's condition very quickly. And that takes me to the next point, that once we are on ionotropes, let's ensure that we monitor for signs of ionotrope toxicity. Heart rates, increasing heart rates, increasing BPs, cold extremities, because ionotropes cause ischemia, peripheral ischemia. We've had an example of a baby who lost a leg because of noradrenaline. So monitor 10 to 15 minutes ionotropes, and once you're told to give ionotropes, please ask for targets. And to the doctors, whenever you write a dose of ionotropes, put a target BP, target MAPS, so that as the nurse is titrating these ionotropes, he has a target. And so once you reach your target, please wean the ionotropes off. Okay, so we have to continue monitoring our patients. Monitor. And as you're monitoring, please record. In nursing, we have a saying, something not recorded or not documented is not done. So always record, because after a few hours, you're going to go off shift and someone will take over. They need to see what you've been doing. So frequent vital sign monitoring is very important. Heart rate, respiratory rate, blood pressure, SpO2, temperature, in this case, RBS, and always ensure that you always check for the neuro status. We have a simple AVPU or GCS, neuro status. It is an indicator whether a patient is also deteriorating or improving. So in our patient, always observe for increasing chest pain. You might, our patient had chest pain, we are told we gave DAPT, adjuvant platelet therapy. Always ask the patient, has the pain gone away? Don't assume that the pain has disappeared because you gave aspirin and clopidogrel. Always ask. So, as you're doing all this, please think of escalating care. We have ionotropes running, meaning this patient might require a higher center or ICU. Communicate that, you know what, we have this patient, we might need to bring them in ICU. Is on 2 ionotropes, meaning is a candidate for ICU. Might even worsen and might need central lines. Might even have to intubate. So you are seeing an SpO2, which is good now. The next hour it might have worsened. So document and prepare for handover. Always prepare for handover. Prepare your transfer notes. This patient, as we've seen, we are suspecting a myocardial infarction, meaning you have to be transferred, as we saw, to a higher facility. In this case, had to be transferred to Heart Institute. So as you're doing your work, plan for transfer. And in your planning, we said, don't forget to involve the family. Document everything, all the assessments you did, all the medication you gave, the response of the patient to those medications, and all interventions that you gave, and the changes in the patient's condition. Always communicate to the family. I will repeat that so many times. And encourage your doctors to always hold family conferences and update the family whenever there is a change. This helps you to move with the family. Okay, so as I'm concluding, I would like to tell you that even in limited resource settings, nurses are fully capable of providing holistic care and life-saving care for hemodynamically unstable patients. All we need is rapid assessment, skilled hands, and our compassionate presence. Thank you very much.
Thank you so much, Mr. Mbabazi, for giving us the nursing perspective on how to handle such patients. Allow me now to invite Dr. Agri to take us through the emergency medical management. Dr. Agri, you're most welcome.
Thank you so much, and thank you so much to the team online that's listening in, and all my participant colleagues. You've made my job much easier because you've touched on the pros and cons literal of everything. But also, I thank my colleague Emma who came up with this case because it represents the kind of population that we are having. There are now more aging people who are living longer. Gone are the days when the life expectancy of Ugandans was 48. It is now much better. People are living longer. So you're going to face these cases every day and every time. So it is something that we need to be ready, but also not panic when you get such a patient. The first thing is that when you encounter this patient already, if it is a standard EMT system, they will have come with a proper good handover of what has so far transpired and also a good handover of what has been administered, but also what has been the changes either for negative or for positive. So at least have a working plan with the patient. And first and foremost, you have to recognize you need a team. So when you get this patient, call up your colleagues so that all the hands come on board, and start with your airway. Make sure that the patient is not getting any worse. If you need to support the airway, start by talking to the patient to see if the patient is able to express themselves. If the patient is able to talk to you, then the airway is really patent. If they are not, then try and do a chin lift, a jaw thrust, and find if the patient can be given supplemental oxygenation. And remember, we are not over-oxygenating. We are making sure that the patient is perfusing, but without getting toxicity from the oxygen. And this can be by simple nasal prongs. It can also be by simple face mask or the invasive methods where we can actually put laryngeal mask airways or intubate if the patient actually has decompensated. And then also the patient, like my colleague has alluded, we need to elevate head of bed so that they cannot aspirate, but also they're able to try and have good cerebral perfusion. On top of that, we are able to try and address the current issues. The current issues are mainly cardiac and metabolic. So the point that we need to understand is when you have accelerated blood pressure, you are resistant but not volume overloaded. And in this instance, the patient either should have been probably having a sympathetic overdrive because of the pain, so the pressure is elevated. And a good response, yes, was good to give the antihypertensives, but Caesar's made it clear that we gave a bigger dose, so we should give a smaller dose. But also, if the heart rate is not as over elevated, then maybe beta blockers may not be the best choice. You may start with just a calcium channel blocker to just lower the pressure. And our target is lower the pressure by at least less than 20% in the first 6 hours so that the patient does not get any worse. If you lower the pressure faster, then the patient is going to have a lot of struggle perfusing the brain and perfusing the heart or the other organs. So you gently lower the pressure and also improve the viscosity by allowing a little fluid. And here we've also agreed that you do a gentle bolus, maybe 200 to 250 mils, and assess for response. And here we are going to look for response by looking at the skin color for those who are light-skinned. You can do just a capillary fill if it has decreased from 3 probably to less than 2. You can also look at the urine output. You can also look at the level of consciousness if it's improving. You can also look at your blood pressure. All these are what we call the static parameters of hemodynamics. But if you have an ultrasound, you can also do an echo of the heart and look at the ventricles and see. If the ventricles are empty, they'll be touching each other, which we call the kissing ventricles. But if the ventricles are moving very well, also you appreciate the wall motion. Like in this instance, you saw the video that was shown, that we have hypokinesis. So it means we are going to be very gentle with this patient's fluid. But also when you do the inferior vena cava on the subcostal assessment, you can also assess and see if the patient is having inferior vena cava collapsibility. If they are really collapsible, it means you can give a little more fluid. If they are really they are not collapsible, they are tight, then you may just now start with the support. And my colleague also showed that dobutamine is the best drug here because it's not going to increase cardiac oxygen demand, but it's just going to improve the contractility because of its beta effects. And also then you improve the afterload by giving the noradrenaline, which is also going to improve the systemic natural resistance by improving the perfusion peripherally. The other thing also is to gently offload the heart by removing the extra fluid with a gentle diuresis. And these are very, very key because we've had situations where people have given antihypertensives and then given diuretics without even giving a bit of fluid bolus. So you reduce the resistance, but also remove the fluid. So the patient's viscosity increases, and then the patient actually just worsens. The other thing also which we need to do here is to continuously reassess the patient. Just one intervention is not good enough, but you intervene, but again, reassess all your parameters to see that the patient is improving. In this instance also, because it was very clear that they had been given antihypertensives, the beta blocker and calcium channel blocker, definitely we got toxicity effects. So when you give the fluid and start the inotropic and vasopressors, then you can also give some antidotes. And here we can give calcium, either chloride or calcium gluconate. You can also give the glucagons, and also you can give insulin. Those are all possible antidotes. But when you give them, then you monitor every 20 minutes for the blood sugar so that you are not crashing as fast as you can. Also, the other thing is to understand that when you're looking at the disability or the D, yes, this case brings out the element of hypoglycemia in the patient, which was well corrected, and you have the option of either giving a D10 or a D25 or a D50. D50 tend to provoke a hyperglycemic spell. So when you give a D50, most likely you need to assess within 20 minutes because the sugars tend to rise and then again crash very fast. But we prefer a D25 because D25 does not cause the same insulin response. You have less insulin resistance. So you find that you have a better rise of sugar without a big provocation of the insulin uprise. And then also, then you check on the pupils because sometimes when you have acute coronary syndrome, sometimes also it's good to find out how is the brain working. This patient could easily stroke because the pressure is one time very high in 200 and then suddenly they crash. So this patient could easily just get another ischemic stroke. So you look out for the pupil size and see if this patient is still having cognitive senses, but also there are no neurological deficits. And if they are, that means we're going to add on a CT scan for this patient. And then also exposure for other problems. Most adult patients have hyponatremia, have weak bones or weak tendons, so they tend to have falls. So just looking at the heart and not looking out around the whole body makes it very difficult. So you need to assess. That means you're going to do from head to toe assessment so that you look out for external injuries on this patient. Could have been previous falls for this patient. So you assess for all these things so that you can understand what else could be going on. And also, depending on what you find, you can take it for further examination or rule out any things like bites, which could be causing venoms or toxins in this patient. And then also we do a quick ample history to understand any past medical history and past surgical history. This patient had surgical history, which was not very significant because they had a prostate problem, but all these things actually help. And sometimes you get collateral history from the patient, or from the relatives, or from the bystanders, or from the EMT team that bring the patient. The other thing that we need to do is to try and have a focused investigation on this patient. Most times we have resource constraints, so whatever you choose should be an intention that we are investigating to fix a problem or to confirm your challenges. So your understanding of the patient's story, symptoms is very, very key in managing this patient. So you have an area of investigations, but you should be focused. If you think it's cardiac and acute coronary, then we can do a complete blood count, a group and cross match, just in case we may need blood. But also you do the cardiac markers, and the classic ones, we have the troponins and CKMB, which were done in this patient. But there are also newer ones, like the heart fatty type acid binding proteins, which are really very good and very sensitive. We don't have them in this environment, but we are improving. Ghana is work in progress. So probably 2-3 years from now, maybe they should be around, but at least there are things you can think of. But also the BNP can be very good in understanding is just a new problem or it's a heart failure that is just getting decompensated. First, ultrasound is very, very good as well if you're well trained, but if you're not trained, just good clinical examination, like in this case, it comes out very well. The patient was feeling cold and clammy. So that tells you how bad the perfusion is of this patient. So you can actually use some of those things to understand what's going on in your patient. And then also, when all is said and done, what are your choices for inotropic support? I like the fact that Caesar's brought it out very well, that half the time your intentions might make the situation worse. When you're going to do vasopressor and inotropes, we prefer you use a very big gauge cannula, preferably big veins, but if you can't do central lines, because if you give noradrenaline, it can actually cause exsanguination of the peripheral vessels, and typically you'll end up getting what you call the purple glove syndrome, like we've seen with the baby who lost the hand. So these are preferably, if you have to use a peripheral line, just use it for a temporary time until you get a central line in, and make sure your drugs are well diluted and running at the right rate to avoid toxicity. But also between adrenaline, dobutamine, or adrenaline, adrenaline is good to start with, but make sure you are keeping it as the lowest dose possible if that's your only drug you have. But if you have better drugs, then noradrenaline will be a better option. But also still keep it the lower dose so that you can only have the alpha effects without getting the beta effects. Once you start getting a tachycardia, then it means you are not achieving the aim of what you wanted the drug. It's time to step up another inotropic drug, and that's now the butamine. The butamine works better of the two drugs because it improves the effect of the contractility of the heart without increasing oxygen demand. The other options of the drugs we have in the periphery is phenylephrine is also a very good drug if you didn't have noradrenaline, but it tends to cause a bradycardia. So if you already have a bradycardia, then it may not be a very good thing unless you have atropine to slightly push back your heart. But yes, it may work very well for patients that may have hypotension and tachycardia. Vasopressin is also very good as well if you are trying to target the peripheral vessels, or if someone is struggling with dobutamine and you can't give too much fluids. And then Merinone is one of the newer drugs. I think Hattis has some of these drugs. So they're not going to be in the lower facilities, they're going to be in higher facilities. But Merinone is very good as a vasodilator, inotropic drug that has a good inotropic effect. So by and large, while you are managing this patient, make sure that you're communicating to the other team, like if you need cardiac interventions, to inform them of what's going on and how soon you can bring the patient to them. Also, there is room for interventional radiology. And I think there are some people now that have trained in Mulago. Also, it's good to inform cath lab if your patient is going to the cath lab. And here in Uganda, cath labs can be found with Mulago Hospital, Nakasero, and Kisubi Hospital. And I think other centers are coming up. So those are places that you may end up trying to discuss with family where they want their patient to go. And then also the different ICUs. Literally in Kampala, every hospital has an ICU, but it's good always to find out if they have cardiac services. Some ICUs do not offer advanced cardiac services. So if you are to dispose of this patient in the government facility, try and coordinate up with preferably Mulago Heart Institute, because then they have the facility. But if the patient chooses otherwise, then probably then you need to find out which other private hospital has heart services before you just send the patient off. And then also discuss closely with your physicians so that they can see which medication would be better to keep the patient much stable, and also have specialist nurses. The cardiac nurses will be the best nurses to work with. However, basic nursing care is still very good enough as long as you know your actual good bedside nursing care. And then also have a chance to document what your interventions have been, and then what are your challenges, and then what are your plans, and then discuss with the family so that they can understand what's going on and what might be the best possible plan. When all said and done, what are your take-home message on this case? We should always learn to treat what first kills the patient. So in this instance, our hemodynamics had crashed. We had hypoglycemia. Those are things you first attend to so that the patient can temporarily survive. And then you go back to the drawing board and say, okay, let's start from head downwards and see what else can we fix. When you start resuscitating the patient, your game is to restore physiology, because most of the patients who are elderly have decompensated physiology, but be gentle when you are resuscitating them. The slower you are in your resuscitation, the better. And you've seen from the trials that have been done, the AVOID trial, less oxygen, better survival. Less water, better survival. Less adrenaline or inotropic support, better survival. So less seems to work very well, especially for a decompensated patient. When we are going through the thought process, let's always remember the H's and T's, or we go back to the mnemonic of vitamin. What are we seeing and what are we missing, and what are our possible problems in this patient? When we're investigating, let's use money judiciously. Let's investigate to affirm our thought process, just not investigate everything, because we have all the resources to investigate. And then when we are giving fluids, we should be permissive. The less you give the fluid, the better the outcome of the patient. The less oxygen you give, the better. But also the less you lower your pressure for the patient, the better. And then we should remember, in this age where there's litigation, communicate, document, discuss as a team, and involve the family in the discussion. Basically, the Indians call it the KISS principle. Keep it simple and safe. Thank you so much.
Thank you so much, Dr. Agri, for that insightful and impactful presentation. At this point, I will invite the audience for any questions, comments that they have. Kindly raise your hand and you'll be given an opportunity to speak. Dr. Sarah, are you online?
Yes, there is Umar Senkubuga who has his hand up. Kindly give him a chance to speak.
Thank you. Hi, my name is Umar. I am an EMS resident at UT Health in San Antonio. I am Ugandan, and I am passionate about pre-hospital care. Okay. I think my question, Doc, thank you very much for the insights. I would like to, mine is not more of a question, it's a request. Can we try to follow the chronology of the patient? Because for this case, for example, the resident is handing over to the patient, to the EMT to transfer a patient, or whether the patient was coming in. I think that distorts care. If we have EMTs and drivers on the call, it would be helpful, for example, in this case, to know how do I use the resources I have on the ambulance to get the patient to the hospital alive. That having been said, I like what Doc said and what the nurse said. I think that should actually be what the pre-hospital care person should have done. If they had done that, then they would have delivered an MI patient already having cardiac aspirin. And so it makes the doctor's work even easy, because this patient presents more with an acute coronary occlusion than an MI. Thank you very much.
Thank you. Andrew, could you please kindly unmute?
Hello, thank you so much. My name is Andrew. My question goes to I think that was the first presenter. In the primary survey, when I looked at this patient had a GCS of 14 and the RBS was 1.7. So I was trying to get this picture. Maybe you could help me understand what was his final way forward on the disability management. Thank you.
Yes, Nabisubi. Miss Ruth Nabisubi, kindly voice out your concern.
Hello,
Yes, we
am I
can.
audible?
Yes.
I'm Ruth, I'm a midwife, and I would like to know how best we can handle a mother who is pregnant that has come in that kind of situation. Is it the same management as you have said? And then with such patients, what physiotherapy management would you give them, and then the nutrition side of it towards either discharge or recovery? Thank you so much.
I think at this point I can invite our experts to respond to those questions as others are coming up. Yes, Dr. Emmanuel, can you respond to the question that was raised?
No, Umar wanted chronology. So probably you can inform me that the case had a bit of modification. It didn't follow that normal. Because it was modified.
All right. So I'm going to respond to Mar and Andrew. So Mar had asked about how patient came in. The handover, was it from the resident to the EMT? Supposed to be the other way around. So for the purpose of the presentation, we had to modify it so that we get the EMS bit how they will actually manage a patient like this. But the chronology of events is the patient was not referred when they came into a facility. They just walked in and said that we have come from another facility. So there was no I would say interfacility transfer, as it would have been in an ideal setting from this peripheral facility to our regional facility, where now they would have been brought in, like the doctors in that facility would have handed the patient over to the EMS team, and then they transport the patient and then now bring the patient to us, and we take the care of the patient from that point. But the patient just walked in from that facility, and then we just managed them in our facility. So the purpose of the presentation, that's why we brought in the bit of EMS, so that because we know there's a patient who needs to go to UHI. So if we are now moving the patient from Barara to UHI, how will the EMS service come in and move this patient? So whether it's by road or by air, or all those things will come into play, just as for the purpose of transporting the patient. But it didn't happen that the patient was handed over from residence to EMS. So I think that's clear. And then Andrew asked about disability. The patient came in confused, yes. GCS was 14. And as part of the initial assessment, when the RBS was done, it was 1.7. So the confusion didn't improve even with the suspension with glucose. And we actually thought the ongoing confusion and restlessness might be due to the chest discomfort, in addition to the hypoglycemia that he had, because his GCS got much better after his pain was well controlled and after he was started with the dual antiplatelet therapy and the inotropes. Well, now he was perfusing well, his pain is well controlled, and he's on anticoagulation and platelet, that's when the perfusion actually subsided. So it is good that you noted that there was the disability element of DCS, of the hypoglycemia. That was corrected, yes, but then the disability persisted until now the whole holistic care was brought in. That's when we improved. Thank you.
Thank you. I hope you've been answered. I now invite Dr. Agri to respond to the rest of the questions.
Okay, so Ruth asked about the obstetric patient with a similar presentation. And rightly so, yes, we have many obstetric patients that actually are getting elderly because either initially they didn't have chance of getting birth, but with the IVF now to give birth. So patients who you suspect patients that are, but also some patients have positive cardiac history, and they've been advised typically, normally, not to get pregnant. But along the way, love happens and people fall in love. You can't deny love. And when the patient comes to you, first and foremost, they'll either come in pain. So your first thing is address the issue of pain. So then you go through A, B, C, D. Give maybe a simple opioid, like either fentanyl or morphine, but try and give on the lower side. Morphine is very good because it is both a vasodilator and an arteriodilator in smaller doses. So it gives you a chance to lower your pressure both in the pulmonary vessel, but also in the heart vessels. And somewhat lower, slightly lower your pressure, but the patient is able to relax a bit, and then you can the patient. And we still do not forget the A, B, C, D, but first and foremost, because an obstetric patient, call the OB team, that's the obstetric and midwife team, so that they come and be part of that assessment as the ENT part of it. If it is early on in pregnancy, our priority is to save mother. So if we do an assessment, first and foremost, pressures are high, we are going to give medication to lower the pressure by 20%. So that our patient's pressures are enough to perfuse both the baby and the mother. And then we may need to give a bit of fluid, which is very good always to do part of the what we call intrauterine fluid resuscitation, and also offer the oxygen, because in pregnancy, oxygen demand is much higher. The mother has a baby who's also feeding on them, so we give them oxygen, and probably our target might even go up to about 94, 95, but at least be seen to be giving them oxygen and a little bit of fluid to improve the fetal well-being. When the OB team arrives, you have to involve the mother or the next of kin, who may be the husband, and decide what is the next plan. If it's all on in pregnancy and the heart condition can be stabilized, then the option most likely is going to be that they keep the pregnancy. And that means we do the echo, we do the ECG, and see how bad this intervention needs to be done. In the meantime, we shall give our cardiac aspirin and the clopidogrel. If the plan is not to deliver the mother, they'll need to get heparin. However, in the event that we think that we are almost term and the mother's condition will be improved by having the baby out, then we have to discuss with the team, avoid giving give cardiac aspirin, but avoid giving heparin, so that the patient can be able to be delivered and the mother's heart condition can improve. Now, the challenge is during the delivery, we prefer this patient has to have an elective Caesar or an emergency Caesar, but not normal delivery, because normal delivery is going to increase stress on that heart. And if they choose maybe to deliver under normal delivery, then you may need an anesthesiologist or an obstetric anesthesiologist and offer them an epidural. And the epidural will offer good pain management and also offer less stress to that heart. But ideally, an elective or an emergency that might be the best option, and then the patient has to be taken to ICU. And preferably, this patient also needs to be we need to have the CAT team involved, because fluid management intraoperatively and postoperatively has to be to the lowest minimum, because during the delivery, there's transplacental, there's uterine transfer of about 25% of the cardiac output that can also decompensate this patient still. So we need to be very judicious or restrictive in our fluid, but also use the right inotropes like dobutamine intraoperatively, and then the patient has to be continuously watched with the 12-lead ECG in the cardiac ICU postoperatively. So our take message on this patient, let's be ready as a team, because these patients are not going to only happen in questions, they are going to happen to come to us. IVF is happening, it's not, and also there are many mothers who are choosing to have children after 40 years when they've chosen finally to fall in love. So be ready.
Thank you, Dr. Agri. Dr. Sarah, would you like to respond to some of the key questions that were raised in the chat?
Thank you so much. I have handled most of them, and right now there are no any other coming through. So I think that's it from me. I don't know if there's any. I don't see.
There is a question that has not come from the audience, but it has come from the house. What is the role of nitroglycerin in this patient? If it was an option to be given, would you have given it or not? My answer to this, if it was available, yes, it can be used as one of the first options. Actually, it's a very good option because it's able to offer a good response in the lower doses. For between 100 micrograms to 200 micrograms per hour, you can lower both your vessel pressure both in the vessels and in the veins and in the arteries. And that means also you are able to improve the perfusion because the nitrates improve perfusion in the heart. So that patient actually can have a very good response, both in lowering the pressure, but also improving the perfusion. The challenge with it, you can't just give it without using an infusion pump. So probably at the lower facility, it was not an option because it's not a drug you just give as a bolus. It's a drug you give as an infusion and titrate to effect a good outcome. But yes, if the patient first reported to a higher facility like Heart Institute on Caesar's side, whereby it's the drug they commonly use, and yes, and he can also make a comment about it as well.
So other questions about nutrition.
Okay. Oh, you can make it. Yeah, you can make a comment.
Yeah. Okay. Thank you. Just in addition, at Heart Institute, we use nitroglycerin for such patients. We have sublingual tabs and sprays. Nitroglycerin spray, they are readily available. Okay. There was also a question about nutrition. A patient who is hemodynamically unstable, we also need to mind their nutrition. We give high calorie feeds, and especially in this case, if we have an energy tube, make sure that we give high calorie feeds, but we mind the volume, especially the fluids. We don't overload. Where we work from, we calculate the amount of feeds that we give, depending on the patient's weight, right? So this also calls for input and output. You chart input and output and balance. We always want to maintain a zero balance. So we have to mind the input. Then someone asked about physiotherapy. In such patients, we want to do DVT prophylaxis. We always do it at Heart Institute. We do range of motion exercises. And since he's already been given enoxaparin, that's also a good thing in DVT management. And also giving DVT stockings. Yeah? Yeah, thank you.
Thank you so much. Thank you all for your participation and thoughtful contribution to today's session. You have been a wonderful audience. Special thanks to our experts for generously sharing their knowledge. We also extend our okay. We still have some more time for questions. We still welcome questions, our dear audience.
Hello, I think I have seen a question on timelines for myocardial infarction management. I don't know if the expert, Dr. Agri, could highlight on that. I don't know, I'm not saying it again, but I had seen it.
Yeah, so the timeline is such that, for example, in this case, we had a delay. The patient had reported late, 3 days in the lower facility, then they came to the higher facility. So you find that your options are limited. You need to make sure that they are not getting another infection. So you're going to start with your DAPT. That means you're going to give the dual antiplatelets and the anticoagulant, enoxaparin. But if they come within an hour of the acute myocardial infarction, then you have a better window of opportunity to actually intervene up to the PCI. So you'll do the cardiac aspirin, the enoxaparin, and also you do the clopidogrel. And you're already offering them oxygen, you're giving a painkiller, the already on 12-lead ECG, and you inform the cardiac interventionist who will come, review the patient together with an anesthesia team, and they discuss with the family, take consent, and take the patient to cath lab straight away. So within an hour, that patient, they can do an intervention straight away and unblock by doing a PCI on the vessels that could be blocked. The challenge is if they've come late now, it may not be something you may not attempt straight away. So you may try and stabilize the patient, because if they've lost the critical time, then it may be very hard to try. However, if the patient still came and the cardiologist are able to review, if they took the patient to the cath lab, sometimes they can look at the vessels and see if there are those they can try and salvage, or there are those they can put stents. So if they cannot put the PCI through straight away, they can just stent them if that's an option. Long term, if they're not able to do that still when the infection has been bad, then they can do a bypass artery graft, where they will get the vessels from the femoral and try and bypass and graft the infected part. So in our environment, it's very crucial that anyone having chest pain is sent as soon as possible to a higher facility, so that the higher facility have a chance to be able to send them to the actual specialist that can be able to have a better intervention and save their heart from having more infection. And that means that window period should happen within an hour's time, which sometimes is very, very hard because of the transportation problem. But it's work in progress, and that's why the EMT is now building up all these services so that people can get to know that when you call the service, they can actually save this time, but also they'll have the C ambulances where they can start intervening by giving you the adaptive treatment and then save your time to reach the Heart Institute. As opposed to when you drive yourself, go to the hospital, and then hospitals find a way of channeling you. So it's better, I think, at the end of the day, I think the EMT team will share their numbers, that people know that in the community, we need to increase the sensitization and knowledge that the EMT services are available. And I think the earlier we start accessing their services, the better we shall improve our needle time intervention.
Thank you so much, Dr. Agri. If there are still any questions, kindly raise them. If not,
Ruth's hand is up. Nabi Subi.
yes, Ruth, you can unmute and voice out your concern. Nabi Subi, Ruth. Yes, Nicholas. Banya Nicholas, kindly unmute.
Thank you so much for the presentation. Mine is more of an inquiry. Number one, I don't know whether the statins would play a role here. And then also investigating the patient for the lipid profile. Because I don't know whether I missed out, because I have not seen any investigation for the lipid profile for this patient. And then the other thing, the morphine. What would be you give the oral morphine for what duration? Those are just some inquiries I wanted to find out.
Dr. Emmanuel will respond to that.
Okay. So thank you, Nicholas, for the question. On the statins, what we have shared with you today here was the management that we instituted in the emergency department. Of course, the patient was later reviewed and more things were added that we didn't want to bring them up here today. But yes, you're right. That was investigated and he was started on statins. That was late after our 24-hour duration in the ED. We didn't do that initially in the emergency management because it was not one of the goals we had. It's not one of the goals of care that we had initially. But yes, it came up and that was taken care of. Morphine, what we did for him, the analgesia, we gave him IV morphine, not oral, because like I said, he was confused, restless, he could not take orally. But then we tapered down the analgesia to we titrated it to the comfort of the patient. So after the first 2 doses of IV morphine, he actually came down and he was just weaned off analgesia completely. When the dual antiplatelet therapy was brought in and anticoagulation was brought in, and he was comfortable, we weaned him off analgesia. So that is what I can comment about the questions. Thank you.
Thank you, Dr. Emmanuel.
That's hand is up.
There is Arthur online.
Hello. Hello, good afternoon. My name is Dr. Arthur Gregorian. I'm a representative of the Worldwide Surgical Missions. It's United States-based non-government, non-for-profit organization. And first of all, I would like to congratulate the entire panel and participants in today's thing. It's the first time I join ECHO, and I think it's very important. I have few, if you don't mind me asking you, unrelated questions to this particular clinical situation. As far as it appears to be not just emergency medical service, but more like a physician-based approach. Is that correct? That's the first question. And second, how can we help you to participate in that from a physician perspective, mid-level perspective, or EMS perspective? System is probably a little bit different in United States. Thank you.
Thank you, Arthur, for raising that. Dr. Agre, can you respond to him?
Thank you, Arthur, for your observation about the approach. You rightly, I think, picked it up that, yes, what we've been discussing is a hospital-based approach. And I think your concerns are very, very valid to see if I was not in a hospital, what else can be done? And rightly, I think in the States, even in the UK, everyone knows if you have chest pain and you're in a certain age bracket, or you already know that you've had a heart attack before, you know, your first go get is take your aspirin and call the emergency services straight away. And one of the challenges we have still, people have not yet bought into using the EMT services. You find that mainly the hospital staff who are trying to use the EMT services, but the community has not yet realized that this is a service that has improved since post-COVID, and it is improving, and government is investing in heavily. And I think your concerns are very right when we say, for example, if someone was out of Kampala in Entebbe and they rightly felt they were having a chest pain, which may be related to a cardiac situation, how do they start their care versus what is recommended in the hospital, which is kind of very systematic? So what I would recommend first and foremost is the first that the numbers, if someone has an idea, yes, they would have an option to take a cardiac aspirin, but then call EMT services straight away to talk to them and ask them about their symptoms and how they can be helped so that the EMT can know where they are and how to come and pick them up. But also if there are numbers that can be called directly on the helpline, you can actually call and ask the physicians online. For example, you say, I'm going through this, I'm 70 years old, my pressure is this, what are my problems, and can I get help? That can be one of the options. So it is something that we need to come up with on how can you approach a high-risk patient in the community who needs to access a good higher facility, as opposed to the discussion we have, because the discussion we have are for already trained medical workers who already somehow may just need to advance their knowledge on how to approach this hemodynamically unstable patient. And so that has been our major discussion for this afternoon. But the community also needs to know what is the simplest things I can do to be able to survive and reach the hospital without aggravating my condition, but at least trying to do the best to improve the situation. So my approach to that would be, for example, I have a sister-in-law who is in Alberta, and I'll use her experience. When she's come to Uganda, she comes with her cardiac aspirin tin. She also comes with a GTN spray. We've been with her to Fort Portal, and we were on a walk, and she literally got an attack. And she sat down and requested to open up her clothing so that she can breathe. And she took her aspirin and she sprayed. And then we called someone in Kampala and we took her blood pressure, and he advised which medication to take, and we went and got nitroconto, which is a nitrate. And we just made sure that her pressure doesn't go any lower than that. But this is one of those patients who travels and they know they have this problem. What about those who do not know? That remains, I think, something that we need to put up in a system, that if someone calls in this situation, then ABCD can be done for them so that they can be able to contact someone for extra help about it. I beg my colleagues as well if they have anything extra to supplement on the question.
Thank you, Dr. Agre. At this point, if there are no any other pressing questions, we are going to display the answers to the earlier polls. Okay. I've been advised that we are going to first have a post test. I think it has already been launched on your screen. Kindly attempt. Okay. As you attempt the questions, I will invite our experts to give their closing remarks. Yes, Dr. Emmanuel.
I would like to thank everyone who created time to attend to today's activity. I think we've all heard and read that the shift is now moving towards non-communicable diseases. So we are seeing more patients who are coming in with such presentations, cardiac and the rest. So this is a very timely discussion. And as Arthur, the last participant who asked the question, is what can be done, I think this is a conversation that we need to have further to actually see the population that we have out there in the community. When they have these kind of symptoms, they need to be well informed so that we don't have patients who are coming in 3-4 days later with such presentations, because maybe we might not be that advanced like in the first world countries, but at least we have resources that can actually help some of these patients if they actually come in time. You've heard of UHI that is able to intervene in patients who present timely. So my take is that we need to have a system that is going to inform our people of what is available for them, so that when a friend, when someone in the village notices that a friend is suffering of chest pain, they can actually advise them to rush to the hospital. 1, 2, 3 things can be done to actually save their lives. Thank you.
Thank you so much, Dr. Emmanuel. Dr. Agri.
Okay, so all of us, as we plan to grow old, need to recognize that at some point we are going to be at this risk. Either it's going to be a parent, it's going to be someone we know, a next of kin, or someone's next of kin, but somehow we get to know about them, or it's us ourselves, and we've lost even a former Minister of Health in Soroti. May his soul rest in peace, the former Dr. Malinga, who died in Soroti. And the nurse rightly admitted she could diagnose, but she didn't even have cardiac aspirin. Things have improved, but there's still more work to be done, because people go for Christmas. I've had a bad situation where a royal person got a myocardial infarction during a meal. So these things are likely to happen. It's just that I think we never have the conversation around the table, what else can be done for the next patient. I think for certain age group, cardiac aspirin should be literally with them. Statins should be with them, because they are a walking time bomb. The body is going to decompensate at some point. And so if someone can have these medications at home, it's very good, but also a facility that can easily be accessed in the community. As the EMT is able to come and reach you, can be able to do something, because they need to find you alive in the first place. So cardiac aspirin is very, very key. 300 milligrams will save your life. Atorvastatin will save your life. But also having a number of a medical worker you can call and talk to ask, understand your symptoms also is very, very important, because sometimes what you need is information to act about your problem, not to stay home and relax and think it's just a normal problem. The other thing is, at the facility, we need to realize that when the patients come, let's not be panicky. Let's admit, yes, there's this patient who is high risk, who has this problem, and how do we address that problem? So the first thing is support them by not being overzealous. So if you're lowering the pressure, lower it just to a 20% by just giving probably one medication. But also fix the things that are likely to worsen and kill this patient, like the blood pressure should slightly be lowered, sugars should be admitted to give this patient, and then give them supportive oxygen and call another peripheral site and discuss with them about your patient, so that the patient, by the time they reach another site, they can also know what to expect, but also what you can fix as you are with the patient. The last take-home message is working as a team is very, very key, because if I'm at a peripheral site that I cannot do everything, I can call for help. So we should probably have some numbers where people are on call. Like I've seen this work in Kawempe. My phone literally never goes off, so anyone in the country can call me for assistance and I can advise them, and I'm happy that there are lives that have been saved without moving to Kampala, but they stayed. Like we've had myocardial infarction, a pulmonary embolism in mothers that have refused to come to Kampala from Hoima, and they needed to make a decision to deliver them. And you've offered help and they've been saved. So sometimes all you need is to call maybe Heart Institute or call Kisubi or Nakasero, where these heart services are, and discuss with them, and they can advise you at that point on what you can do, and that can improve the outcome of the patient. Thank you so much.
Thank you, Dr. Agri, for those remarks. I invite Mr. Mbabazi.
Okay, thank you, Dr. Betty. I thank you all for having attended this session. We are grateful that you came and attended. Otherwise, it would have been disheartening if we are talking to ourselves. So thank you very much. And also my fellow experts and panelists, I thank you. You've done a great job. For me, mostly I want to talk to my fellow nurses. You know, you're at the center of management of emergencies. So let's do our work the way we are supposed to do it. We offer holistic care. That is the difference we have with all other people. It's holistic. Here we look at the entire patient. So as we are concentrating on the high BP and whatever, let's not forget that there is a person in front of us. There's a lot we can do, but our care should be patient-centered. Maybe lastly, I'd also like to inform everyone that referral is part of management. So do what you can. Heart Institute has a lot of capacity to handle such patients. The 3 days this patient spent somewhere would have saved him a lot, and he reached Heart Institute. So if there's something you don't understand, but it involves chest pain, do what you can and refer them to Heart Institute. It's a government hospital. The rest of the things will be talked about when they have reached. Payments and what can be talked about when they have reached, but refer them so that they get to decide here. Thank you very much.
Let's have Ms. Kevin to give us her closing remarks.
Thank you so much, Dr. Betty. Thank you so much, team. And thank you so much to all that attended. Now I would like to talk about this advice goes to the EMT members. Let us continue doing our work. We are trying to bridge that gap between the hospital, the community and hospital, plus these facilities, so that we transport this patient and get to another hospital properly. I think many people are not using that EMS service because people are not aware of it. Some of them, they are not aware of it. But it's better to use our services so that we transport your patient safely. Your patient is in good hands when he's with the medic, transporting them, than taking that patient yourself. Because we go on monitoring that patient, we give medication on the way. So it is better to use the EMS service. Maybe some people don't have the numbers or access to the EMS service. And I would like to share some of the numbers you can contact within Kampala So that in case you have any patient you're referring, you don't just give them a referral letter, you go to Kawempe, you go to Mulago, you go anywhere. So you contact the EMS team, they come and take that patient safely, so that we stop that thing of patients dying on the way. They were taking them to Kawempe, taking them to Nagulu without EMS. So here are the numbers, some of the numbers you can contact. There is 0761 61 9431. That is for Nagulu ambulance station. Okay, thank you. Okay. And another one is 07.
I think that the numbers will be shared on our different social media platforms.
Okay.
Okay, the numbers will be shared on the social media platform. Thank you.
Thank you so much, our dear experts, for those closing remarks. I hope the audience has been able to learn a thing or two from this session. As the post-test is still ongoing, we are going to read out the answers. I will hand over to Dr. Agri to give us the answers and maybe a few explanations behind the answer.
From the primary survey, oh, sorry. Yeah, from the primary survey, what are the three major conditions in these patients? That's kind of straightforward. We had a hypertensive emergence, and then also later the pressure has crashed, so we end up having a cardiogenic issue because the pressures had crashed, but also the patient had already had background chest pain, and then an issue of hypoglycemia. So that actually the majority of people answered that question very well. Then based on the above information, what are your management options for this patient? And several answers were given. There is the issue of noradrenaline, adrenaline, IM, infusion of adrenaline, give phentolamine, and give IV fluids. And in this instance, our pressures had gone down. There was no overt bleeding, so it means it's cardiogenic. So an alpha drug would be very good. Noradrenaline becomes a very good drug because we are trying to improve the resistance and so that we can create a good afterload. So there will be better perfusion, but also fluid in this instance will worsen because 1 liter is a lot of volume. It will decompensate the patient. Phentolamine will just lower the pressure. IM dose is good. Normally we are using it for anaphylactoid reaction, so it would not be the thing you give here. And then adrenaline infusion will increase a lot of beta effects, which will worsen our oxygen demand for the ailing heart. And then the number 3 is what is the oxygen saturation target in the management of acute coronary syndrome or MI. And I remember the avoided trial, the oxygen was at least between 90 and 94, and that showed better outcome. And that's what, based on the study, that is the recommendation. Too much has a lot of toxicity, so, and also too little has a lot of systemic vascular resistance. So if you're targeting below 90, you're still going to create a lot of pulmonary resistance, which is going to increase a problem on the right side of the heart. So it will not improve the situation.
Thank you so much. At this point, I would kindly request our dear audience to switch on your videos. Kindly switch on your videos.
From the Stone City.
Maybe just to mention, our next EMS Echo session will be on the 11th of July. and we shall be discussing approach to a convulsing patient. If a patient came to your emergency department convulsing, how would you approach it? If you are the EMT, you have been called to go and pick a patient who is convulsing, what are your considerations? The nurse who's taking care of a convulsing patient, what are you going to be doing as a nurse?
Stroke. Convulsing stroke.
Yeah. An advocate of obstetrics. Yeah, so the convulsion could actually be because of preeclampsia or eclampsia. So we shall be covering all those in the next session. Thank you so much. We are very excited that we've had such a great panelist, and the topic has been well handled. The session materials will be uploaded to our website, which the link has been shared to the chat. If you haven't yet seen it, you can take note of it. And also we shall upload the link to the video recording of this session still to our website. We shall make an initiative to also upload the numbers of the regional emergency coordinators so that you can be able to utilize the emergency care teams that help with transporting the patient timely to the facility. Thank you all for coming. We're very excited for seeing you on.
Thank you.